another dose. In this video, we have a 45-year-old female who presents with a history of recurrent ureteric calculi. Her biochemistry reveals that she has hypercalcemia, hyperchloremia, and hypophosphatemia. Her alkaline phosphatase and serum parathyroid hormone are also elevated. What is the most likely diagnosis? Alright guys, so give this question a try. Drop your answers in the chat and or jot it down. You can pause it here and let's see if you can get this one. Alright, let's hope you get it correct. Let's see what the answer is. So this question is basically an endocrinology question, or if you're doing MBBS, it would fall under internal medicine. Alright, and this particular topic is, as the topic gives it away, primary hyperparathyroidism, right? Particularly PTH-mediated hypercalcemia, right? Or it can come under calcium oxalate stones. So if you're discussing kidney stones, it could come under that as well. All right, so the answer for this is primary hyperparathyroidism. So if you got this one correct, give yourself a pat on the back. You did good, right? So basically analogy. So you can think of PTH as the manager of calcium, right? So PTH is trying to manage calcium in the blood, right? He's trying to keep as much calcium in the blood as necessary. Not too much, not too little, just a balanced amount. But the problem now is in primary hyperparathyroidism, the manager, which is the PTH, has gone rogue, right? It's gone completely nuts, and it just keeps on shouting that it wants more calcium, right? You can think of Battle Beast from Invincible saying more, 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 right? So, so PTH it just wants more calcium. It's shouting more calcium, more calcium. So as it's doing that, it's just hoarding all the calcium in the blood, right? So even though there is already enough calcium, it continues to flood the bloodstream with more and more calcium, right? That calcium, because it's so much in the bloodstream, it ends up spilling up into the urine, and that's why you form kidney stones in hypercalcemia, right? And even while all of this is going on, the phosphate gets dumped out of the body, right? And we'll see why in a second. So this is the explanation for it, right? So the patient basically has PTH-mediated hypercalcemia, right? So there's increase in PTH, which is parathyroid hormone. There's also increase in calcium. So both of these strongly suggest and points towards primary hyperparathyroidism. And the most common cause of primary hyperparathyroidism is a parathyroid adenoma. Remember that. Recurrent ureteric calculi is equal to classic stones from hypercalcemia. So remember what we're saying, where there's a lot of calcium in the blood and it spills over into the urine, forming kidney stones. This is what's happening in there. Right? So recurrent ureteric calculi, that's classic, 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 and that's often in the form of calcium oxalate or phosphate stones. All right? So those phosphate stones is another reason why the phosphate is lowering in the blood. Now, the next point is there's in primary hyperparathyroidism is that you have decreased phosphate, right? So hypophosphatemia, low amounts of phosphate in the blood. That occurs because the PTH increases the renal excretion of phosphate, right? So increases renal phosphate wasting, basically. So there's more phosphate in the urine, otherwise known as phosphaturia. All right, the last key point in primary hyperparathyroidism is that you have increased alkaline phosphatase. What that suggests, or increased ALP, is that there's increased bone turnover. So that basically the PTH stimulates osteoclast activity or osteoclastic activity indirectly via the osteoblast signaling, right? So when the PTH basically causes increased bone turnover, that leads to more bone reabsorption, right? So that's why the ALP increases. Just to add a note, hyperchloremia can be seen in non-anion gap metabolic acidosis pattern associated with hyperparathyroidism, right? So it's often discussed with hyperchloremic metabolic acidosis. associated with the primary hyperparathyroidism, right? But the deciding features of this, and important to remember for this question, or questions that they should bring similar to this in the future, is that whenever you see increased calcium, increased PTH, decreased phosphate, as well as kidney stones, you want to think primary hyperparathyroidism. Okay? So let's just have a brief discussion on why the other options were incorrect, right? So secondary hyperparathyroidism, that's due to chronic hypocalcemia. So you get that in chronic conditions like chronic kidney disease, vitamin D deficiency, and so on. Right? So in secondary hyperparathyroidism, you get increased PTH, which is, of course, what you get in all hyperparathyroidism. But the calcium, no, that's different. Calcium tends to be low or normal, and well as the phosphate is often high due to the chronic kidney disease, right? Tertiary hyperparathyroidism now, again, there's autonomous PTH secretion after long-standing secondary hyperparathyroidism, right? So tertiary hyperparathyroidism is technically due to secondary hyperparathyroidism, most commonly from CKD. So the PTH, of course, is going to be high again, but in this case, it's going to be very high. But you can also have a very high calcium, right? So both of those, so that's why the primary and tertiary are kind of similar in that respects. But you would expect them to mention chronic kidney disease in the history, and the phosphate in this would actually be higher, not low. Remember, with primary parathyroidism, the phosphate is low, and there's no history of chronic kidney disease. So that's what separates this one from primary hyperparathyroidism. Now, hypoparathyroidism, that's out already because in the stem they said the PTH is high, right? So in hypoparathyroidism, you have low PTH, as the name suggests. You'd also have low calcium and a high phosphate, again, which is not what was in the stem. Now, quaternary hyperparathyroidism, that's not really a standard or commonly accepted clinical diagnosis. So they don't tend to test that in the clinical setting, right? So you don't have to worry about that. Now, just want to mention this table we got from Curbsiders Internal Medicine. Listen to their podcast. If you want to check out their podcast, feel free to do so. I tend to listen to those podcasts when I'm on the way to work. They're really, really good podcasts. Them and the Step 2 to 3 podcasts, USMLE podcast, something like that. But yeah, Curbsiders is really good as well. And they have this nice table on primary hyperparathyroidism, which you can see here. PTH is high, calcium is high. So you want to remember that medications like thiazides and lithium or calcium supplementation can mask primary hyperparathyroidism, right? So the indications for removal of the parathyroid, because remember we said the most common cause of hyperparathyroidism, primary hyperparathyroidism, is a parathyroid adenoma, right? So you want to remove the actual lesion, the parathyroid. So the indications for removal, they say here, the age is 50 or less than 50. If the calcium level is more than 1 milligram per deciliter above the upper limit of normal, that's what ULN stand for. Renal dysfunction, if the patient has any renal problem, if they have kidney stones or high risk of having kidney stones, so you want to get renal imaging and 24-hour urine. And then fragility fractures or osteoporosis, right? So for that one, you want to get a DEXA scan and vertebral fracture analysis or spinal films. So that's just something to consider and to remember with primary hyperparathyroidism. All right, so basically the high yield takeaway from this is that whenever you see a question, they mention that the patient has, or in the hospital, and mention that the patient has high calcium, high PTH, low phosphate, and kidney stones, you want to think primary hyperparathyroidism until proven otherwise. Key thing to remember is that the usual cause of primary hyperparathyroidism is a parathyroid adenoma, right? And then the next thing is if the PTH is high, but the calcium is lower normal, you want to think secondary hyperparathyroidism, right? And remember, primary hyperparathyroidism and secondary hyperparathyroidism both have the high calcium as well as the very high PTH, but they tend to have chronic kidney disease in their history, and they tend to have a high phosphate. Right? again, the high phosphate is due to the chronic kidney disease, right? So yeah, that's basically it. I want to thank you guys for watching. Before you go, if you could really help to hit the like button on this, it really helps the algorithm to show it to more people who would be interested in this kind of content. So I'd really appreciate it if you hit the like button. Drop a comment below. Tell me what topic you'd like to see next. I already have one request for the next video, but still drop your comment and I'll add it to my list, and we'll definitely shout you out if you want me to shout you out, and we'll discuss that topic as well. But I like to do case-based questions. So if you send me a topic, I'll do a case-based, find a question relevant to it, and then discuss the topic through the question. All right. I think that's the best way to learn it. All right. And yeah, so just share, so like, comment, and just share this with your friends, your family, whoever you think might be interested in this topic, whoever you think this might be relevant to. If you're studying, especially for MBBS or USMLE, I wish you all the best on the exam. And yeah, I'll see you guys in the next one. Bye for now. I'll see you guys in another dose. All right. Take care.